but we will see. All right, so we're back on the record in the OJ matter, you guys, before your time. First time we saw a very interesting trial, and people began to become very interested in forensic evidence. The O.J. Simpson trial, arguably the most famous athlete. It would be like Aaron Rodgers murdering somebody. It would be like that kind of thing. It's a legendary player. Crazy. But as we saw that, so we're not going to go through it. Quick note, and the only reason I tell it to you because we talk. You're chattering in the back. It's okay. It's near the holiday. You're forgiven. This one time. After this, 20 lashes with a wet noodle. I used to have an English teacher who used to say that. He loved the girls and hated the guys. My sister was like his favorite student 5.5 years earlier. And he just begged for me to be sick. I was that kid. Front row. Would you ever miss a day? No, because it'll make your life too easy. It's like I had a little director's chair with my name on it in detention. You know, you would have guessed that, wouldn't you? Never. Moving on. So why do I say this? Because this time last year, October, was last year, I had prostate surgery. Okay. The complications of my bladder cancer had eventually caused effectively prostatic hyperplasia, which thankfully was benign. And there's a lot of procedures that are done, and many of them are not, and it was very unpleasant. So as you can see, age related. So 80% of men age 70, I'm 72. So there's nothing unusual about it. And anything that complicates this process, like bladder cancer and treatments, and you can have a lot of problems with it. So for years, we used to do these transurethral resections sharply with blades to sort of widen the passageway and remove prostate. He did this with what he called a green laser. And I was shocked at how well it went until after it started to heal. Then I wasn't so happy. Okay. I mean, I spent a couple of months, it was just awful. As finally and they explained that was the normal process. My friend in Florida, they did a procedure where they basically intentionally clogged the arteries going to it to shrink it. He said it was extraordinarily painful for 2 days and then really good, and it really didn't work. So I asked my surgeon about it. He goes, long term, they're not as good. Short term, they're pretty good. So there's all sorts of nuances with this. And you know, even for many of you, it's not going to affect them. The guys you're all probably going to be affected by it in some way, shape, or form. So I thought I'd mention that to you. It's as common as anything in prostate cancer. I mean, after lung cancer, prostate cancer is the most common cancer that we see. Skin cancer and lung cancer. You know, for men, that's the same way we have skin cancer, lung cancer, and breast cancer. Breast cancer would fall into that second after lung cancer in women. Just to make that note. So prostate, as you can see, it kills slowly, not rapidly. We usually don't see fulminating prostatic cancers. It's relative. Most people they die of other causes, even though they carry that diagnosis. I commented before, for years, there wasn't anything really reliable. So they would do a digital rectal exam to see if it was enlarged, or you could palpate any irregularities, which is part of a standard medical exam for men after X, whatever age is. And then they discovered that you could monitor this with this prostatic sensitive antigen. And so the two of them together have been, and even with people with prostate cancer, you monitor that for treatment. If it goes up, there's a problem with the treatment. If it goes down, then the treatment's being successful. So it's a really important measure. Not unlike when we get to diabetes, when we start talking about something called hemoglobin A1C. You know, a relatively new test that's available over the last X number of years that has made it a little bit easier to work on diabetics. So again, and the treatment is rather interesting in that it's funny, both breast and which we talk about a little bit about in the next unit, and prostate cancer both have a remarkable tendency to metastasize and spread to bone. But they do different things in bone. Okay. We see in bone, prostate cancer is what we call blastic. What that means is you see areas in the bone where there appears to be more bone. And breast cancer is lytic, so it's almost like punched out, like you took a hole puncher. That's one of the ways you do it. When you see punched out lesions in bone, you start thinking about a woman breast cancer, maybe lung cancer. Very, very interesting. For those going on in that direction, there's so many interesting clinical clues. And to me, every time you hear somebody talking about them, try to put it in here. The best thing you can be in life, wherever you're going, is somewhat of a sponge. Sponge. I'm not talking about a sponge sucking up everything. Yeah. When you hear somebody who has at least a certain degree of knowledge, so normally I frequently talk out of my chapeau, as my dad used to say, talking through your hat. And you may recall the term we use for now talks about talking out of your anal orifice. Oh, see, you said it. You know I don't like to swear excessively.
You say it in lab at least 5 times. Okay.
We're stopping the recording now. I'm purging it. You're going to tell Dr. Gatt. Okay. So effectively, anatomically speaking, seminal fluid is a teaspoon or less. An inordinately large amount, maybe a maximum of the better part of 1 billion sperm, because when we get into the physiology, it requires that many to finally get to where they're going, so to speak. Fructose is the sugar that's utilized for that. And again, it's activating it, it's facilitating it. It's somewhat alkaline in nature, neutralizing acidity of the male urethra, and particularly the vaginal area in the female. So all of those are part of it, and both the seminal fluid and the prostatic fluid play a role in both of these. So the prostaglandin, and this is interesting physiologically, because they were first isolated, they felt they were all from prostate, decreases viscosity of the mucus, reverse peristalsis, relaxin to enhance motility, ATP, suppressing immunological response, antibiotic chemicals to destroy bacteria, clotting factors, because once you're trying to prevent drainage out. It's very, very fascinating. So I just thought I'd tell you about that. And we don't do a whole lot about this, more physiology. Basically, it starts with parasympathetic, and the climax or ejaculation, and depending on whether it's male or female, is about the sympathetic nervous system. And we'll go through all of those things that are there. Not a whole lot. I've commented very, very little. It's not no. It should be N with a capital O, because it's nitric oxide. If you go back and read articles over the years, there's a lot of, I don't think there's been anything definitive to prove or disprove why this has become such a significant increase over time. I mean, temporarily, medications you could understand, alcohol you could understand, psychological factors you could understand, but why it's so pervasive now as it wasn't before is really, I don't know, it's controversial, but perhaps not well understood. We certainly understand it when it's vascular in nature, and this is, when we get to diabetes, this is a big player. That's one of those interesting early warning signs of hidden diabetes in the adult 30 to 40-year-old male. I'll tell you an interesting anecdote about that down the road. And when we get to the physiology part of the program, and sildenafil when Viagra was first put out in 25 years ago, that Viagra was obviously a trade name. Sildenafil is the marketing name. Okay, that's the generic name. Viagra is the trade name. And again, a lot of misunderstanding about it, but it's extraordinarily effective in most and extraordinarily profitable for the folks from Pfizer who have had a few winners. The Z-Pak was from Pfizer. This is from Pfizer. These were multi-billion-dollar drugs That's when you want to have their stock. We're not going to go into spermatogenesis. A little bit about the cells. Within those seminiferous tubules, it's not just cells that are spermatogenic, okay? So there are a lot of those. There are these sustenocytes that are supporting, probably play a role. Myoid, these help to sort of squeeze them out and into the fluid. Myoid for muscle-like. And then these are famous, the interstitial endocrine cells of Leydig or Leydig. They are the testosterone producers. So the similarities, again, with what goes on in the ovaries are certainly something to be considered. More so in physiology than anatomy. We've seen this before. I mean, this is kind of what it looks like inside. And we're not going to do a summary or anything like that. And this is, you probably, I mean, it's so, they're basically being produced after mitosis. And when you look into it, these are, we don't have the thing with polar cells or polar bodies. So effectively, when an egg becomes viable, it's really a 1 out of 4. Here, this is like a 4 out of 4 type of thing. And you can see they're basically produced as a relatively unremarkable cell that eventually grows into such a way that we eventually identify the sperm cell itself. And they'll talk a little bit about the sperm cell without going into all this stuff. Here it is, basically through that developmental process, and this part being carried on in the development process being carried on in the epididymis, and finally being released as what we call mature sperm. And this is the other anatomical nugget to finish. There's 3 parts. The big part of any consequence is the head. The head has a little helmet-like structure called the acrosome. That contains the enzymes and is the accumulation of multiple sperm that are able to penetrate the outer coating of the egg. And we do this at the end of physiology. We look at this again. I do the fertilization, growth, development, and unfortunately the aging, which we will not discuss. What they call, what's the name of it? It's basically, it derives the word senile. I begin to think some days I am. I couldn't find my phone. It was sitting on a table in the lab, and I didn't see it. It's over now. So again, if you get contacted by someone with a Navy.mil address named Stein, did my dad do anything that we can put him into the home? Don't respond, please. He'll try. He's like that. So the acrosome is part of it. Underneath the acrosome in the head is effectively the haploid genetic material. The mid piece is really just about moving the tail, which is the flagellum. So this portion is inconsequential vis-a-vis the actual act of fertilization. Is all about getting it there, so to speak. So there's not a whole lot. It takes a fairly long time. So when they're produced, they can't swim once, and that happens in the epididymis, etc. We don't go into all the compartments. There's the barrier, and that's why they have to be kept separated, because they're produced at puberty. So your self, non-self, that will cover a lot in immune system is not applicable to the development of sperm. And again, I'll reiterate, and we'll get to it more when we do that unit. It's more pervasive than you think. We use the term infertility, and it's remarkable how, I mean, I might make that number a little more conservative. It may go into a lot of the things when we start talking about the increase in prostatic problems, the increase in erectile dysfunction. I'll give you the summary. My first wife and I, for 5 years, worked very hard to try to have kids biologically, realizing there was a problem. She had polycystic ovary disease, so we knew that was a problem. And she had multiple procedures trying to facilitate it. That's also a problem. Eventually, circa 81, 82, we went to Hospital University of Pennsylvania in Philadelphia at the Penn campus and saw the man who was considered to be the greatest living authority on infertility, Dr. Celso Ramon Garcia. So he saw him directly, and basically this was the summary. He said 60% of the time it's on the female side, 20% of the time it's on the male side, and 20% of the time we don't know. Unfortunately, all the tests and all the intervention were unable to help us. Another couple that we were in a support group with up in Squirrel Hill, the support group was basically women, and the husbands obviously got together for infertile couples, and there were quite a few. They went to see him. He was unavailable. They spoke to his chief resident, and she had endometriosis, which is another major troubling problem. He was able to recommend antibiotics of a certain type for a certain duration, and she was pregnant within about 2 months. So it just doesn't always. It's very interesting. It doesn't always work. Unfortunately, I think that we lost contact, even though our kids were born almost exactly the same. Our first children. They only had the one child, a girl. But she died in 2009. It's another one of those reasons don't Google. It's like, oh, I wonder what happened to her. Oh, here you go. Yeah. Never good. Oh, they send you the link to the obituary. That's not good. Okay. So, and there's all sorts of different things that are there. You can see antibiotics, radiation, evil weed. Evil weed. Always what?
Always.
You were born in the wrong era.
No, they still have weed in this one.
It's better than ours. It was better than ours, and ours was much more intricate to acquire back in the day.
He dabbled in it. I don't know.
For every day for 7 years.
Did you okay, questions. Did you smoke it? Did you eat it?
Smoke.
Okay.
We didn't have edibles too much, unless people put it into like hash brownies, which I thought that was a waste.
How did you smoke it off?
Huh? I didn't.
She was a really good one.
That is no. When I was in undergraduate and when I was in podiatry school, yes. As soon it was sort of an agreement I made with myself when I started my residency after I got my doctorate. It was I can accept making a mistake that I make, honestly, and maybe hurting somebody or worse, killing somebody. But I can't accept it if I'm under the influence and stuff.
So,
Never since.
Did they not have drug tests?
They did have drug tests.
They did or didn't?
They depending on your field, they did. My buddy down in Florida, he quit for 6 months because he was having a drug test when he had moved to Florida, and basically tested because it takes 3 to 6 months, hair samples and things like that, which even were around then. So yeah, it's very, very interesting in that regard. I was never in a field that required that until much, much later, and certainly not for here or anything like teaching positions. One might say it might have been encouraged. Yes. But no, if you work in like when I wanted to, I'm trying, in other workplaces it's different. So I mean, every time my son has a CDL with hazmat, every time not only if he gets a job, if there's an accident, before he can do anything else, they have to go get a drug test. Before he starts, if anything happens at all, boom, get a drug test. That kind of a thing. So yeah, the answer is it's all changed a lot. I think it's very much different. Like for instance, a lot of people in my generation probably don't smoke it so much as now they're more into the legally acquirable edibles and things like that. And people are into it. I don't anymore. I kind of said after a while, having been addicted, if I didn't tell you, to pain pills for a long period of time, to codeine-containing pain pills and barbiturate-containing pain pills, that I got out of that completely. I just won't use it anymore. Any of it. It's just like smoking. After 40 years of smoking, my kid were on the golf course with his buddy, and the two of them are certainly not smokers, but they occasionally like a cigar. Hey, Dad, we got these really great cigars. Where they got them? I said, no, Well, why not? I said, I love them, but I made a promise I'm never going to do that again. So same thing, even for pain medicine. If I have surgery, none of those surgeries I ever take painkillers. I mean, ibuprofen, sure. Anything that would be scheduled, no. Whatsoever. Just me. So we'll talk more about this down the road. So, overuse of hot tubs. We have one on the deck. We're in the deck. Hot tub for 4, which fits 2 comfortably. Small. Mojitos, midnight, hot tub. What? Doesn't it sound good?
Yes.
So, and this is all physiology, so we're not doing it, and we're not doing it, and we're not doing it, and that's about baldness. We're definitely not doing it. That's it. Male is complete. On with the show. So this one, to be honest with you, the complexity in the female and in the male is relatively limited anatomically. The complexity of the physiology in the male is not terribly complicated. Other than this, again, a litany of things that can go wrong. In the female, it's very, very much complicated in physiology. That takes a while. So for those of you in MCAT, we tend to do, because they come at the end of the term, we tend to do repro and urinary early on. Because some of the people who will take MCATs, let's say in April or it gives them some time to have a certain degree of familiarity. So we do it a little bit out of sequence when Dr. Hilwig and I do the MCAT class in that way. But and what's interesting, unique about the physiology is it's basically 2 physiological loops and a variety of hormones, both pituitary based and ovarian based, that have 2 cycles that we have to marry together. We have a cycle for egg production called the ovarian cycle, and we have the menstrual cycle. And how do we marry the 2 together and the events? There's a lot of complexity. And when you learned early on about feedback, which we talked about very first lecture, negative and positive feedback, this is one of those areas where you see more positive feedback, but we say that for physics. So same deal that we had before. Hopefully we won't freeze up. And this reproductive, more complex because of pregnancy, obviously. The female gonads, the ovaries produce the ova, and again, that's their exocrine function because it exits by way of a duct and carried by way of a duct for fertilization. And the secretion is endocrine because it goes directly into the bloodstream, and that's estrogen and a variety of byproducts, as estrogen is sort of the body tinkers with it chemically, and progesterone. The internal genitalia within the pelvic cavity, again, we're not dealing with the testicular aspect of descendedness, is the ovarian and duct system, which includes effectively the uterine tubes or fallopian tubes, whatever you want to call them, and the uterus, the vagina. The cervix is the neck-like area between those 2 structures. And then external genitalia. So we have labia, minor and major, and the clitoris, et cetera, et cetera. And so it's a little bit different. And the first notable thing is the overall proximity between rectum, vaginal entryway, and urethra. So you have 3, and immediately that proximity creates a lot of problems. And interesting, and then the relationship here, which obviously don't have testicularly, since they're not within the abdominal pelvic cavity per se, is you have the location sort of sandwiched between and overlying, and this is the normal way that the uterus is held, overlying the bladder, so you can see when someone is pregnant why they have to urinate so much, because the pressure that's upon it. Okay, add between the rectum, and you can see that sort of sandwich. So that in itself is another sort of interesting little bit of anatomy that's part of it as well. And there's a lot of things, and I don't delve into all of the anatomy. I try to simplify it. Again, if you're going into a field, whether it's in medicine or a related field or physician assistants or anything along those lines, you again, the degree of detail increases dramatically with regards. So you can see where the ovaries are located relatively close. Unlike the relatively long tubal structure for sperm, this is relatively short. Each tube is about 4 inches in length. Interestingly, you can see those finger-like projections over there. They're called fimbriae, which is a term. Finger-like projections named fimbriae, you might recall from micro. Okay, how bacteria attach. You had flagella, pili, and fimbriae, which are kind of like short. That's how they attach. So it's a little bit different. So it just means finger-like projection. They're important. We'll get to that shortly. So we'll begin to look at all of these. We'll look at the infundibulum, sort of the opening of the structure that's there. And you'll see that fertilization typically occurs sort of in this neck of the woods. Carried down to the uterus, there's a dome-like portion, same name that the stomach dome-like portion has, the fundus. And obviously entry points on either side. We're just looking obviously at a cutaway. You can see the cervical area here, this tiny little opening. Okay, and then the vaginal area. There you could have these vestibular glands or Bartholin glands, which are kind of analogous to the bulbourethral glands. We don't have anything that's analogous to the prostate or to the seminal glands in the female. So we don't have an analogous structure. Moving on. So flanking the uterus, relatively small, almond shaped, about twice as large as an almond. That's there, so not very big. The ligaments, again, are folds of connective tissue that most that are denser than you think, but not by no means as dense as a typical ligament, let's say a knee ligament. It's not really analogous in that regard. And collectively, you're going to see on the medial aspect of the ovary extended to the uterus, something called the ovarian ligament. Laterally to the side or the side wall of the pelvis, suspending it, suspensory ligament. There's more mesentery-like material that suspends the ovary. Together, again, like we said in my old neighborhood, together. Together? What? No New York East here. Ugh. I'll go red up something. Yinzers. Good. I have to get in touch again with my inner Yinzer. Nevertheless, what happens is collectively, these structures are called, I think, the broad ligament more than anything else. So suspensory ligament, the mesoovarium, and even to some extent the ovarian ligament become this elaborate broad ligament that has blood vessels and nerves and supporting structures throughout. What's interesting, in most systems, the interior does a lot of work, more so than the exterior. Not so with the ovary. Egg formation starts and sort of works its way around. Okay, on the exterior, in the cortex of the ovary. The interior is more about blood and nerve supply. So it's a little bit different in that regard. Okay, so the ovarian follicles at various stages of development containing immature eggs. And finally, as you'll see as we move on, where the egg is sort of expelled, like over here, in that area. There are two areas of important blood supply. The gonadal arteries, when we looked at the vascular tree, you have the gonadal arteries, which come directly off the abdominal aorta. Okay, we're good. Now, there's an ovarian branch of the uterine arteries. That's a little bit different. Okay, the uterine arteries, and this is the uterine arteries are the ones, branches of that uterine artery, not only go to the ovaries, but most importantly, those are the arteries that undergo spasm, called spiral arteries, that are all about menstruation. They come off of the internal iliac. Remember, the external iliac carries on, goes down to the lower extremity. The internal iliac sort of services the central interior of the abdominal pelvic, particularly more so the pelvic category. Just like testes, it has a firm, fibrous outer capsular-like layer called the tunica albuginea, and then a layer of peritoneum that surrounds it, the so-called germ, which is covered by this germinal layer. So here you can see, now there you can see an ovary sort of in action as the follicle starts here. One particular egg is selected. We go over this in physiology. Matures, enlarges, and is expelled at ovulation, and the enclosure effectively changes and becomes an alternative glandular structure called the corpus luteum. Luteum indicates yellowish, and it's yellowish in color anatomically, and that takes over the production of estrogen and progesterone for at least 10 days if there's no implantation, and then it basically involutes, shrinks, becomes no longer there or no longer functional. In the event of implantation, then it takes over until the placenta develops. So it's an important structure. And here's the big anatomical nugget. Sperm are never released generally. Remember, you have that barrier, that testicular barrier, the blood. Not so here. Eggs are expelled into the abdominal pelvic cavity. Yes, in close proximity to the opening of the tubes, but no, it's not closed. The tubes don't surround that opening where it opens up and basically pops out. There's a little gap space. That gap space will every so often, relatively rarely, result in an ectopic pregnancy. What does ectopic mean? It's not where it's supposed to be. So it can be in the abdominal pelvic cavity. An ectopic pregnancy could be implantation in tube, probably more common, with things like that. So that's, and they're big deals because they typically create big problems that are there. And it relies on little threads of mucus that extend, and the tiny cells, which are kind of variants of pseudostratified columnar epithelia, the cilia create little currents that induce the egg into the opening of the tube. Yes, ma'am.
So can women have an ectopic pregnancy without any complications?
Yes.
For their baby?
But that's the exception.
So it's like rare.
From somebody who never had the privilege of having children biologically, I'm amazed when it occurs. I mean, it's as miraculous as anything. There's so much stuff going on for it to be right. It's crazy. I mean, and sometimes your people are they're fortunate. My wife was pregnant 7 times, 5 healthy children, 1 stillbirth, 1 miscarriage, 1 full-term stillbirth. And we tried everything, first wife and I, everything. You name it, we did surrogate parenting, in vitro fertilization, which all of that was in its infancy. People looked at us like we were charlatans. Oh my God, I mean, and I was one of those idiots. And I use the term advisedly. You may consider me still to be one of those idiots. So I don't want to raise somebody else's kid. My reluctance. I should have stuck by my guns. Look what I got. Go ahead.
Going back, you said that it was 60% usually in infertility. It's
Female-oriented, 20% male, and maybe it's changed today. This is the better part of 50 years.
Is it because of diagnoses like endometriosis, PCOS, and is it just makes it harder? Like it's possible, but
much harder. Yeah, I think today a little bit easier, and it's interesting that here's my son. Obviously, no biological ties. My oldest, and he and his wife, both of those children are IVF, in vitro fertilization. Patty, my wife now, the third of her 4 boys was 4 boys, dead and girl. Kev, who lives here in Pittsburgh, they conceived via IVF. She's due pretty soon. We're just kind of waiting. That'll be her first grandchild, biologically speaking. She's stuck with mine. Sorry. I give my kids a hard time, but they give me a hard time, not my daughter. She's perfect. Other than that, dating the 65-year-old guy, I'll get you the website. You want to be in on this? You could be. It's just, this is absolutely true. I got to tell you. So the guy, he's whining and dining her, buying everything expensive. Uh, got tickets to, whose concert was it? Miley Cyrus at the Hannah Montana days at the Civic Arena. Way back, and you're about the same age as her daughter. Okay, the granddaughters. He got a suite of rooms for them at the William Penn, not cheap. Had a Rolls Royce show for them. I mean, all that type of stuff. He's a cardiologist down in North Carolina who originally came from Long Island. Okay. I can't even tell you how much money he spent. He says, I'll build, talking to my wife and I at the time, not her mom, my wife and I, going, I'll build you a house, and if you want to be in practice, I'll set you up, or we'll find you a teaching, all down there. About 3 months after it's about Thanksgiving, whenever that was, and about 3 months later, my daughter calls me, can you believe he died? No, thank goodness. Thank goodness, because he had at least 2, if not 3 adult daughters roughly her age. And I said, first thing I said, I hope he didn't put you in the will. She goes, Dad, I would never take a penny. I would never do that to his children. That's because she's not that. Her moral compass is strong enough for that. It was startling, and we had this conversation they have a very expensive Sunday brunch at the William Penn, ridiculous, pretty good. A champagne brunch, not that we were drinkers, and I had more to say that it was like we were a kindred spirit. We were born in the same era. 2 Jewish doctors from the New York metropolitan area. And why not? I digress. So I'm glad you don't want that. I thought you were one. Don't start. Nothing, dear.
Don't be rude.
I'm not being rude.
Yes, you are. It's the holiday season.
Yeah, all right, here we go. So moving on. So that's what we'll go into that physiologically. You can see it's not, as long as this is the fundal dome, effectively the uterus is just a massive smooth muscle. And we'll get into the layers, probably not today, that are there. This is that broad ligament. So you can see aspects of it here. You can have this so-called ovarian ligament, which is really just part of this broad ligament. You can see blood vessels and nerves that are in there. The ureter embedded to some extent. Again, we talk about this being anteverted, or the uterus normally being forward and overlying the bladder, which is not of any consequence unless it's enlarged, or certainly during pregnancy. And you can see the ovary, and they're sort of depicting the tunica albuginea and all that, and all these other. There's a lot of ligaments. We don't go crazy going into it that are there. So the ovary has the cortex, that's where the eggs are, and the inner medulla, which is about blood vessels and nerves. So it's interesting in that regard. The follicles are tiny. They have the immature oocytes, and unlike sperm production, which obviously you all know this, that doesn't start until puberty, you're born with effectively, the modern thinking is maybe not 100%, but that there still may be some potential ovarian development, but approximately all of the oocytes are rested in what phase? You're taking genetics now. Prophase 1. That's a physiology test question. Get used to it. So they're arrested in prophase 1, good to go. Okay? So each month, one side or the other, typically, alternatively, one is selected, however that accomplishes for ovulation. Does not have direct contact. That's the big, big point. with the tubal system, and that's the tubes, the uterus, and subsequently vaginally, fallopian tubes, oviducts, a lot of names, receive it, and usually they occur somewhere in there closer to the uterus than to those fimbriae. But it's only about 4 inches long. Okay. The opening with the fimbriae is called the infundibulum. That's a name we hear a lot of, uh, biologically or anatomically rather. Ciliated projections that drape over it. Half of the uterine tube length, and that's typically where fertilization, sort of in the mid portion, and it narrows as it gets about 2/3 of the way to the uterus superior lateral entry point, upper more close to the fundus than anywhere else, and that's where it enters. The uterine tube captures it, sweeps it in. Peristalsis again, ciliary act, all smooth muscle. Non-ciliated cells of the tube provide a certain amount of nourishment to both the oocyte and the sperm. Externally covered by peritoneum, and the mesentery is called the salpinx or mesosalpinx. I do not know if they do it today. Part of the workup back then during fertility was called a hysterosalpinogram, where they actually had to inject radiolucent, radio-opaque dye into the tubes and X-ray. We didn't have the luxury of advanced scanning techniques that we do today. They were, relatively speaking, in their infancy. So every time we wanted to see something, we took radio-opaque dye and injected it in something, whether it was a blood vessel, whether it was an artery or a vein, or intravenously, or the same way even with gallbladders. We had IVPs, and IVC was an intravenous cholangiogram. So it's blood that would accumulate in and around the liver, and particularly outline the gallbladder for stones. We didn't have all the advances that we do today, particularly in imaging. Okay? Same illustration, don't get much out of that. Here's your ectopic, peritoneal cavity or in the uterine tube, and it's not just fertilized, but begins to develop an implant. Most of the time they do abort, and there's a problem. And the problem is, because of the bleeding, you generally have to go in and remove. So now you cut your chances of pregnancy substantially when you have an ectopic like that. It doesn't mean they wouldn't necessarily be born, and probably if you had to deliver, it would be, I'm sure it'd be C-section if that was the case. And this is the big player. We'll talk more about this when we do our unit on, not our unit, but sort of this unit I like to do with this group on a variety of disease entities, and that's very famously PID, pelvic inflammatory disease, which is the culprit associated with most would be the appropriate term, sexually transmitted diseases. HIV would not necessarily be in that, but chlamydia, gonorrhea, trichomonas vaginalis, which are the big players, certainly chlamydia and trichomonas vaginalis, that all have the potentiality to lead to increased ectopic pregnancies, pelvic inflammatory disease, early on ectopic pregnancies, early onset hysterectomies, early onset menopause. All of which are bad. Okay, the uterus itself, relatively thick-walled, obviously receives, retains, nourishes. Normally, its proportion is called anteverted. During excitation vis-a-vis sexual intercourse, it kind of tends upward, and it's called retroverted. That's designed so it facilitates the entry of the sperm. Where the baby is going to be implanted, hopefully, the body. The fundus is the upper portion. The isthmus is as it narrows. The opening itself is referred to as the cervix or cervical canal, and you have an internal opening and an external opening. The os, you have glands that are there. They're important for sperm entry. Again, we looked at it a little bit in the previous chapter. So somewhat of a, those prostaglandins serve to affect that. And we'll leave it here. This is the whole HPV thing. So HPV, more about cervical cancer than anything else. Now, I teach this in microbe. Viruses account for 15 to 30% of all cancers in us. I would dare say half or more of those are attributed to HPV, to the various types of HPV, human papillomavirus. Okay. We just, in micro, I discussed the vaccines. I'm happy to discuss it with this group. And when we get done with the anatomy, talk about pap smears, the same thing. We do this, et cetera, et cetera. So you can see the number. This book went to bed nearly 8 years ago, I would think, probably about 2016. So they're undoubtedly going to try to sell us another edition soon. So if, this was, think of that, killing half. Pretty bad. Most really young childbearing years. So everybody have a wonderful break. Get these things in. I will be in tomorrow. And I have a lecture between 11 and 12:15. I'm usually here between 10 and 11. And I have a lab between 2 and 4. So I usually am here until then. If I'm not in the office, shove it under the door, throw it in my mailbox. I don't care. I want to see it. Be done with it. Goodbye.